I have no disclosures to make related to this presentation. Liposuction is now one of the most commonly performed cosmetic surgeries in the United States. And it's not only plastic surgery that is involved in providing this kind of procedure, but many other specialties, especially dermatology. When liposuction was first performed in the 1970s, it was always done with general anesthesia, and major blood loss was the most frequent complication. But newer techniques have come online in the last decades or so, especially the super wet or tumescent techniques, where liposuction is performed totally by local anesthesia with minimal blood loss. And this classification is a courtesy of American Society of Plastic Surgeons. It just lists the main ways of performing liposuction, starting with the so-called dry technique, the one that was first developed under general anesthesia with significant blood loss that's very rarely in use nowadays. But we're mostly going to concentrate on the super wet technique and the tumescent technique, which are the more popular techniques of performing liposuctions today. Tumescent liposuction involves infiltration of very large volumes of very dilute lidocaine and epinephrine in the subcutaneous tissue to make it tumescent, and that leads to widespread local anesthesia with minimal blood loss. The advantage of this technique is that it can be done completely under local anesthesia, eliminating the risk of sedation and the potential complications associated with that, such as respiratory depression. No supplemental intravenous fluids are necessary in this technique, since no anesthesia is provided, and the amount of aspirate is recommended to be less than 3 to 4 liters. The super wet liposuction, or the semi-tumescent technique, is called that way because it results in less infiltrate and less tumescence compared to the tumescent liposuction. The infiltrate solution contains epinephrine, but not always lidocaine, which means that it will require additional anesthesia, whether it is sedation or sometimes general anesthesia. The protocol for this technique allows for a larger amount of aspirate to be removed, usually more than 4 liters, which makes it more dangerous than tumescent liposuction. Lidocaine is used in the tumescent liposuction technique, and doses as high as 55 milligrams per kilogram have been used. Historically, the maximum dose of lidocaine was considered to be much lower, as low as 7 milligrams per kilo, but it's surprising to see that there is very little scientific evidence as to what the appropriate dose of lidocaine can be. There's numerous factors that are considered to be facilitating the increased dosage compared to the historical low maximum dose of lidocaine, such as vasoconstriction that's induced by the epinephrine in the infiltrate, the fact that the adipose tissue has decreased vascularity, that the lidocaine is diluted, so the absorption is slowed, and the fact that sequestration of lidocaine may occur in the adipose tissue. So it's become fairly clear that the maximum dose that can be safely administered is clearly greater than 7 milligrams per kilogram. However, the upper limit that's recommended, which is 55 milligrams per kilogram, has not been appropriately studied. The peak plasma levels of lidocaine can be delayed for up to 8 hours, which means that these patients can be in danger of lidocaine toxicity even many hours after the procedure is completed. So it is important to do a very careful preoperative evaluations of those patients, and especially the medications that can inhibit the metabolic pathways for lidocaine. And there are many classes of drugs that can inhibit the cytochrome P450, leading to a higher risk of local anesthetic toxicity. Benzodiazepines, opiates, antibiotics, statins, calcium channel blockers, angiotensin receptor inhibitors, tricyclic antidepressants, anti-seizure medications, erectile dysfunction drugs, and immunosuppressants are on that list. And this is another table showing the same drugs now listed alphabetically from alphentanil, alprazolam, to valproic acid and verapamil. The safety of liposuction hinges on two main factors. One is which technique is used and the extent of the procedure. The other would be the number of cosmetic or other cosmetic procedures that are performed at one time. And it's notable the fact that the majority of death related to liposuction happen when this is performed under general anesthesia. Complications that can occur during liposuction include local anesthetic toxicity, such as significant cardiac arrhythmias, fluid overload, pulmonary edema from the irrigation fluid or intravenous fluid that are administered, but also the possibility of fat embolism when the fat is suctioned. Anesthesia for liposuction can be provided with both local or sedation or general or regional, such as spinal or epidural anesthesia. We keep in mind that these are most of the time outpatient procedure, and rapid recovery is expected for those patients. When liposuction is performed under local anesthesia, it usually involves tumescent liposuction, which has an intrinsic limitation on the amount of surgical trauma due to the maximum dose of local anesthetic that can be given. When general anesthesia is involved, it can be more dangerous for the patient because it allows the possibility of excessive trauma or too many procedures in one session. So it's not the anesthetic per se that is dangerous, but what is allowed or what can be done to the patient under general anesthesia. Also, many of those procedures are performed in an office-based setting, which can introduce additional risks related to maybe inappropriate patient selections to be performed in an office, or the level of skill of the provider, which may be different in an office versus a hospital, or the limited resources that can be available in an office compared to a more well-equipped surgery center or hospital. The 5 main factors associated with increased morbidity include large volume of liposuction, usually more than 5,000 milliliters, the fact that multiple procedures in addition to liposuction are performed in the same session, leading to cumulative surgical trauma, increased levels of intravenous saline administered to the patient, which can put them at risk for pulmonary edema and fluid overload when it's added to the large amount of infiltrate, and performing the procedure under general anesthesia, which does not allow an early appreciation of the signs of lidocaine toxicity, and again will allow multiple procedures to be performed in one session. In summary, liposuction is a very common cosmetic procedure. Tumescent technique performed totally by local anesthesia appears to be the safest. Maximum dose of lidocaine is still debatable, although doses as high as 55 milligrams per kilogram are being used. They're not well supported by literature, which means that a thorough understanding of lidocaine metabolism and drug interaction are paramount in order to avoid complications associated with liposuction.